Sure. Well, obviously, NYCBS is a, oncology-based practice. It started out as a smaller group and has grown, tremendously over the past, 10 plus years. So there are a lot of subsections. You've got, a lot of medical oncologists that are sort of the backbone of the big group, but then there's a lot of allied fields that deal with oncology. So, they have, general surgeon, breast. They have even like nephrologists and primary care physicians because you have to have people taking care of these oncology patients as well. It's definitely a team approach, which is where medicine's been going for the last 10, 15 years, especially for oncology. So you also have radiation oncologists who treat in a certain way. And then, in urology, we're an oncology, not only field, but certainly an oncology-based field in a large part of what we do. So I think that was the draw to kind of have a urologist joining up to New York Cancer, several years ago. So I think now the big group probably has pushing, probably 18 to 20 urologists, and it's throughout the New York City area. So from our standpoint, we have urologists, some that do much more primary care. Like when I say primary urology care, BPH and large prostate, voiding dysfunction, things like that. I did a fellowship training in more surgical oncology and minimally invasive surgery. So like in our pod in our group, I certainly focus more on the urologic cancers. And so that melds in well with NYCBS because, we have obviously medical oncologists that I work with dealing with, the chemotherapy side of the urologic cancers. You've got radiation oncologists who deal with the radiation treatment side of things. And then I'm on the surgical side of things. It's similar in the sense that you're having everyone get seen by everyone that needs to be part of the decision-making process. The difference I would say is that, and it's not a huge difference, but in an academic setting, and this is what I had when I was in my fellowship, you may have one little clinic where you have, the medical oncologist, the surgical oncologist, and the radiation oncologist all at one time, one place. And so, listen, it's easier in an academic setting to do that. In a private practice world, it's not always as easy to get it set up that way. But everything is well organized, through our central EMR system and through our central sort of network where, within a short amount of time, people will get set up to see, a couple of things. They'll get set up to see, whoever needs to be part of the care. Again, whether it's medical oncologist, from my standpoint, surgical oncologist, and radiation oncologist, and it'll get set up very efficiently in a short period of time, as well as, lab work that has to get done, imaging. All the imaging is done in-house as well. So although it's not in one place at the same setting at the same time, it's still well organized. So within a short period of time, everyone's, been touched in terms of who needs to be as part of the care. Anyone that's operating has to be part of a hospital, one or more hospitals. Like I'm on staff at 3 different hospitals, all of which have robotic surgery. There's different levels of expertise. I have one hospital in the city I go to that's got a longer track record of robotic surgery. There's one in the island and one in Brooklyn Hospital that, are smaller hospitals, but it's essentially the standard of care these days. I've been doing it for a long time, but you'll find, somewhere around, probably 2011, 2012, just to focus on prostate cancer, that's where robotics really kind of started out robustly from urologic cancers. Around that time is when the shift happened from open surgery to robotics, like where you had more, robotics started, mid 2000s, but around that time, early to 2010s is when you started having more being done robotically than open. And so nowadays, it's kind of like a battle royale where every hospital had to get robots and more robots. But now, honestly, it's like having, basic equipment. You have to have that instrumentation to be able to do what's expected these days. So, listen, we're in the New York City area. So, access to care in terms of getting things at a hospital is not tough. If you're going to be in, rural Midwest, mountain region, anything like that, it may not be quite as easily accessible to have that. Here, you'll have, like I have my block time, where it's my set time to bring cases in. So, from that standpoint, it's really not a difficult thing. It's expected. I do a lot of endoscopic work, same thing. We have cameras, lasers, and ways to do biopsies that are all minimally invasive. But certainly at all of these hospitals, most of that, we have access to all that. Now, in terms of the brand new equipment that comes out, I mean, the bigger the hospital, the more resources they have. Maybe you'll get some of this equipment earlier, get to try it early, get to buy it earlier. And again, that's what we're lucky to be in this area we are, where it's a high catchment area.